Hi, this is Brian Kim. I'm going to share with you case number 190 in the best way to do cataract surgery series. This is a patient with a cataract, a hypermature cataract, and then you're going to see application of trypan blue, and then the execution of terminal chop, cross chop, and mechanical fracturing. And essentially, when you approach these hypermature cataracts in this manner, you're able to bypass and avoid the dreaded posterior plate phenomenon. So this is the case. You can see how dense this cataract is. I use a cotton tip to steady the eye and center the eye. This is a corneal marker, which will help me to center and size a rhexis. I'm turning the eye downward. I make my paracentesis incision first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then intracameral air, and this is trypan blue. I'm going to very gently apply trypan blue and paint it onto the anterior capsule surface. Sometimes with these cannulas, it is a little bit of an abrupt movement of the plunger, and so you can get an abrupt application of the dye. And this is dispersive viscoelastic to push all that out and to coat the corneal endothelium and flatten the anterior capsule. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then when I'm ready to enter, I control the eye with the cannula and I enter. These are the sharp tip Haldane-Perkar forceps. I puncture the center. You can see there's a little bit of a flap that's formed. The tear went to the left. So I use the closed teeth of the forceps, almost like a cystotome needle, and I'm able to control the tear. Grabbing the tear, and then I'm going around circumferentially, trying to control the size and centration of my rhexis. These low profile forceps are very helpful, especially in these cases where there might be some intracapsular pressure. Burp some viscoelastic out, and this is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge, contra-incisionally, point the tip down, get a nice wave, decompress on the left side, and you can see the lens begins to spin. Oftentimes with these hypermature lenses, the cortex is kind of fluffy and milky, so it's easy to spin the lens. Go back with the forceps and grab that piece of capsule. Adjusting the sleeve, irrigating the surface of the eye, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma. With the bevel down, I'm trying to remove the surface epinuclear material. There was hardly any. So that, again, that's a sign this is a really dense lens. Go bevel up, and I'm switching to the dense cataract mode, and I begin to sculpt. I'm sculpting, and you can basically stay the diameter of the rhexis for this. Trying to widen the groove, and you basically want to go deep in the center. Just like a peanut M&M candy, the densest part is going to be right at the center. So you want to be able to debulk that central dense core. But you don't have to go too deep, and that's the nice thing about this technique. I don't go all the way down, and I don't have to depend upon a red reflex in the traditional stop and chop technique. You go about 60-70% deep. I place the chopper around the lens contra-incisionally, and this is on the terminal side. That's why it's called terminal chop. I'm able to fracture from the terminal side, propagate the chop all the way through and through, and this conquers the posterior plate phenomenon. I place the chopper around the right heminucleus, pulling it centrally toward the phaco tip, fracturing the lens in half against the phaco tip, which acts like a chopping block, and that is a cross chop. I do the same maneuver against that first quadrant with the cross chop maneuver and bisecting that in half, using some vacuum to lift that fragment up, and then crushing the lens between the instruments and then emulsifying the lens piece. Using some vacuum to grab that fragment as well, sandwiching and crushing the lens between the instruments once again. By crushing it into smaller pieces, you're able to use sparing amounts of ultrasonic energy and more efficiently emulsify the lens piece. separating that second quadrant from the rest of the lens, making sure there's no deep adhesions there. Placing the chopper around the lens equator, hooking the peripheral lens. Again, this is another cross-chop maneuver around that second quadrant, separating the lens pieces, using some vacuum to grab that fragment up, getting the instruments around the lens, crushing it in half, using mechanical forces, and then emulsifying the lens pieces. It's very important that you know how to position the instruments around the lens so that it effectively crushes the lens in half. And that really just requires just some bimanual dexterity and just knowing how to sandwich the lens, hugging the lens with the chopper on the other side, and then crushing the phaco tip on the near side. And by doing it this way, you're able to successfully crush the lens and chop the lens into smaller pieces without the need for ultrasonic energy and vacuum. Once the lens pieces are small enough, you can keep fracturing the lens piece and then use sparing amounts of ultrasonic energy and vacuum only to emulsify and remove the lens pieces. I turn that second heminucleus in front of me, getting around it with the chopper, placing the phaco tip deep in the bag, fracturing the lens completely in half. By placing the phaco tip deep in the bag, I get a better forces applied around the lens to get around the meat of the lens, and then you saw a effective through and through chop. Some people get worried about the deep placement of the phaco tip, but remember the phaco tip is acting like a chopper. I am not using any vacuum or ultrasonic energy in those moments. It's just acting as a mechanical instrument. And again, I'm using it as a chopping block to chop the lens against the phaco tip with the chopper. What I noticed here is my chopping was rather inefficient. I felt like the tip was clogging. So rather than continuing, I take the chopper out, fill the chamber with dispersive viscoelastic and coating the corneal endothelium, which is not a bad thing to do anyway. And then we went ahead and just cleared the tip outside the eye. Oftentimes with these hypermature cataracts, you have to be very mindful. Even though I'm able to perform very gentle mechanical fracturing techniques, it still doesn't change the fact that those big chunks of pieces have to go through the phaco tip and exit the eye, and sometimes it can clog the tip. So again, applying some vacuum to position the lens piece and then crushing the lens piece between the instruments into smaller and smaller pieces, and then emulsifying the lens pieces, removing the lens pieces. This is the last quadrant. I'm hooking the peripheral lens with the chopper on the other side, on the distal side, fracturing against the phaco tip, which is acting like a chopping block. Since there's no epinucleus, there's no cortex, there's nothing to protect me from the posterior capsule, I'm being very mindful. And again, high infusion and not using high vacuum is really important in these situations. Why? Because if you use high vacuum and you get purchase and you're holding the lens piece, you can get sudden loss of resistance and you get that post-occlusion surge, which can invite that posterior capsule towards the phaco tip. By utilizing these mechanical fracturing concepts and techniques, you never have to worry about post-occlusion surge. Why? Because you're not applying that high vacuum in this setting. You're just pulsing the vacuum. So because you're never going to get high vacuum, you're not going to get post-occlusion surge, and therefore you're going to have less likely chance of rupturing the posterior capsule. How do I know this? Because I performed traditional chop techniques for many, many years. And I notice on these dense lenses, sometimes as the tip clears, you get post-occlusion surge and the posterior capsule flies towards your phaco tip and then you get a small hole. I've done that. But since employing mechanical fracturing, and using sparing amounts of ultrasonic energy and vacuum. And because I'm mechanically fracturing the lens pieces into smaller pieces, I don't get the post-occlusion surge, and I have not ruptured the posterior capsule since employing this technique on these dense lenses. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the ironing handpiece. I'm removing some fine lens material on the periphery. Again, there's no epinucleus, there's hardly any cortex in this hypermature lens. I switch to polish mode, polishing underneath the rhexis edge. Polishing the posterior capsule as well, especially in that subincisional area, just to see if there's any fine lens material. Invariably, there is in some of these cases. Again, polishing the posterior capsule a little bit more here as well. The polymer tip gives me excellent control and safety to clean the bag this way. Once the bag is completely clean, with the irrigation on, I'm pulsing with the BSS cannula in the subincisional space, and you saw that lens material came flying out from the subincisional capsule fornix. So that technique is really quite helpful and has helped me quite a bit to clean up the bag thoroughly. Turn off irrigation, pushing cohesive viscoelastic to fill the bag, and then using the sweep to polish under the rhexis edge, but also helps me polish into the subincisional fornix. You can see there's a big goober that comes out. I'm able to clean the difficult to access areas. So again, the reason why I like this technique is I already have these instruments in my hand. I love the polymer tip. And with bimanual IA, you don't really have that polymer tip. And so I would rather do it this way. Like I said, I can polish the posterior capsule very confidently with the polymer tip. And this is the reason why I like to do coaxial INA with the polymer tip. Widen the incision. I always put in a 3-piece lens with these super dense lenses because I do feel like there is a correlation with zonulopathy in these cases as well. I feel like the 3-piece lens provides more circumferential and wider peripheral support. Invariably, when you're trying to place the injector in, it causes viscoelastic to come out. I push some more cohesive viscoelastic to fill the bag. Go ahead and dial the leading haptic into the bag, making sure the optic comes out flat, the trailing haptic out of the eye, using the multiman to dial the trailing haptic into the bag. Now I have both haptics in the bag. I don't have to worry. I go in with irrigation off, activate irrigation, quickly get underneath the lens, removing the viscoelastic from within the bag. Nudging the lens to get it to rotate. Oftentimes, when you rotate the lens, you can get it to center a little bit better. Switch to polish mode, polishing under the rhexis edge. Switching to visco mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a hypermature cataract, a Catarock. You saw terminal chop and then cross chop, mechanical fracturing concepts and principles. Again, with terminal chop, you're trying to avoid the dreaded posterior plate. You want to think about the lens like a peanut M&M candy. The densest part is going to be the peanut, and of course, the densest part is going to be the center. So when you are grooving for the terminal chop, this is not standard stop and chop. With standard stop and chop, you keep grooving until you start to see a red reflex. You would never do that with this technique, and you don't need to. And with a dense lens, it's just really scary when you do that because you don't really have epinucleus or cortex. And so you can go about 70%. You don't have to go all the way down. And then you place the chopper around the contra-incisional lens along the terminal side or on the equatorial side. You fracture from the equatorial side, But that fracture point is through the posterior aspect of the lens, but it's just on the terminal side. And because you've created that groove, you have space and you can crack, and that crack will propagate along the entire length of the lens. Why? Because I debulked the center. You've essentially weakened the lens and you're able to create a fracture point which propagates through and through. And then you saw I was able to form cross chop, which allows me to fracture the lens from a variety of angles. You get around the lens, hooking the peripheral lens, pulling it centrally toward the phaco tip. The phaco tip is deep in the bag. I'm able to fracture the lens against the phaco tip, and the phaco tip acts like a chopping block. And I perform this multiple times throughout the case. And more importantly, you're able to efficiently fracture the lens without utilizing any ultrasonic energy or vacuum. You're able to achieve, as a result, clearer corneas post-op day one, a more of a wow factor for your patients, especially if this patient's got a giant cataract, their vision's terrible. And if you can do a gentle surgery and save the patient their corneal endothelial cells from a future corneal transplant, and then also, since you're not utilizing high vacuum and high ultrasonic energy, the chances of post-occlusion surge is lower, therefore the risk of posterior capsule rupture is lower. The chances of a corneal wound burn are near impossible because you're not applying pedal to the metal. You're not going to get that clogging. You can get clogging, but you're not going to use pedal to the metal techniques to emulsify the lens piece because you don't do that with this technique. You're fluttering the phaco pedal because that's what you normally do, and that's normally sufficient. Why? Because you've broken the pieces in such small pieces utilizing mechanical fracturing. So this is why I believe this is the best way to do cataract surgery in the hypermature cataract case. So I hope this was helpful to you, and I thank you for your attention.